A very good afternoon, everyone. It is with great honor and pleasure to welcome you all to this 22nd Pediatric TB Eco Clinic in collaboration with the Regional Pediatric Center of Excellence for Tuberculosis. The Eco Clinic is a dynamic platform for case-based clinical discussions and dissemination of knowledge and bringing together all experts across the country for managing tuberculosis among children. On behalf of National Institute of TB and Respiratory Diseases, I extend a very warm welcome to our esteemed Deputy Director General TB, Central TB Division, Dr. Shobhini Rajan and her team. I also extend a warm welcome to Dr. M. Singaravelu, IAP President-elect 2026. I would also like to welcome all the directors and representatives from NIRT, NTI, state TB officers, directors of STDCs, esteemed faculty members from various medical colleges, district TB officers, medical officers, pediatric TB specialists, and all healthcare professionals participating in today's session. Now, let me please introduce the faculty from NITRD. I am Dr. Dhulika Dhingra, Specialist Peds at NITRD, and I will be moderating today's session. And with me is Dr. Sangeeta Sharma, Chief in charge of the National Center of Excellence for Pediatric TB and also former director of NITRD. To my extreme right is Dr. Alok Yadav, CMO NFSG and pediatrician at NITRD. I would now request Dr. Sangeeta Sharma to please address the gathering and also welcome Dr. Shobhini Rajan.
So we are back again this month with a very interesting case. And we had the support of none other than the headquarters of the Central TB Division, our DDG TB, who is the lead of the TB program in the country. And also, we will be joining, or I think has Dr. Singaralu joined? He's not joined. So he might be joining later, but now we also have the IAP president-elect who had kindly agreed that he would be also joining in because we need the support of each one of you, and I want you to who are spokes to further spread this program amongst your colleagues, amongst your residents, because it's a learning platform in which we learn from each other. So I'll request our DDG TB, Dr. Shobhini, to say a few words. Dr. Shobhini, please.
Thank you, Dr. Sangeeta. A very good afternoon to all the participants who are amongst the state TB officers, STDC directors, nodal officers from nodal and district DRTB centers, medical college faculty, district TB officers, WHO GOI consultants, and other colleagues. At the outset, I'd like to congratulate NITRD, who, in collaboration with the national program, are conducting the National Difficult to Treat TB Clinic with a dedicated focus on pediatric TB. We are all aware that pediatric TB presents unique challenges, especially in terms of being identified and the difficulty in obtaining the bacteriological confirmation, and also the fact that we have to rely on clinical and radiological judgment many times. And this is further compounded in cases of drug-resistant TB, extrapulmonary TB, and TB among very young children and adolescents. So we do recognize and appreciate all of you for this specialized expertise that you bring into the program by providing us this clinical understanding of pediatric TB, which is then later on disseminated to the periphery through forums like this particular Eco Clinic. So the objective of this kind of an initiative is basically to provide the structured expert consultation and hand-holding. And I'm sure all the district and nodal DRTB centers who are joined here will help, it will help them in managing complicated TB and DRTB cases through the case discussions, etc. that happen. I'm told that we have a very interesting and complex case presented by the team from AIIMS Rishikesh, which is about the management of TB-associated hemophagocytic lymphohistiocytosis. So just because I am also a pathologist by qualification, I have seen these this picture in the bone marrow, and it does look. It's something that our clinicians used to, our pathologists used to ask us to identify. So I am clearly intrigued by the current case, and I'd like to stay on and listen when we discuss this case of this 2-year-old female child and how the diagnosis was made and how the AIMS Rishikesh team took the case forward. So thank you, and I wish everybody a very productive session, and back to you, Dr.
I will request all those who have joined, they can attempt the pre-test questionnaire, the link for which has already been shared in the chat box. We would also be sharing the post-test link after the session. So it would be useful if you attempt the pre-test questionnaire now, before the session starts.
So, words of encouragement from Dr. Shobani. Yes, this is a very interesting case, a very unusual presentation of TB. And, it's not that we need to spread this knowledge. It's absolutely true that because the case was referred to AIMS Rishikesh and they managed it superbly well, that it's a favorable outcome. And that is the reason we selected this case to be presented in this platform, because it can, such a case can happen we can be confronted with anybody can. So that is the reason we are here. And I think he's still about to join, although I just received a call. So, Dr. Dhulika, I think we proceed further without wasting time.
Yes. So today's presenting team is AIMS Rishikesh, led by Professor Meenu Singh and Dr. Vyas Kumar Rathore. The case will be presented by Dr. Manmeet Singh Khalsa. So over to you, Dr. Manmeet, for the case. Dr. Manmeet, actually there is a band that is coming over your slides which is hiding bit of your slides. You can start. Your audio is not very clear.
Please increase the volume. Your volume is less. Increase your volume, please.
Now is it okay?
Yeah, it's better. ये अगर हम present करें तो ठीक आएगा. If what the team from NITRD can put on your slides, because there is a band. There are two bands which are visible. One is the horizontal. The other is the vertical band on the right hand side. Just try once again. Otherwise, I'll request our program manager, Ms. Shifa, to upload your slides and start it from a side.
Good afternoon, ma'am.
Yes, good afternoon. Okay, sir, you joined, yes. So we have our president-elect, the Indian Academy of Pediatrics president-elect for this year 2026. He'll be taking over as the president from January next year. So I requested him because we need the blessings of IAP so that more and more pediatricians will join in this learning platform. So, sir, I would request you to say a few words till we are sorting out the slides. Yes, please.
Thank you, Sangeeta ma'am, for your invitation. I am extremely sorry for joining a bit late because of my commitment in my college. After that, I was returning home. There was a thank you at the outset without wasting much time. Madam, this is one of the wonderful moves you are doing, and we are in the process of eliminating TB, which is not happening still as we expected we the government and we the private sectors jointly wanted to eliminate TB, and your work is really laudable, ma'am. Definitely, and your way of working and disseminating knowledge to the practicing pediatrician as well as our postgraduates will be definitely very useful and help them to identify and what are the lacunas existing and how to do the appropriate investigation and because nowadays people were using TB as a antibiotics in one point of time. Any child having repeated respiratory infection without going that they will take one X-ray, see will some shadow, they will start ATT. So it was that now the scenario has changed. Of course, we have reduced the incidence of TB, but various forms of presentation of TB is still existing. Definitely, this learning platform will be very useful to our budding pediatricians as well as our postgraduates. Definitely, madam, during my tenure as a president of IAP 2027, definitely such academic platforms should be promoted very well, and we will take up through our IAP and disseminate the knowledge to all our 50,000 members. Apart from that, our various through our pediatric medical education shell, we will spread to our all medical colleges so that people will be benefited. Thank you, madam. So I don't want to stand in between signs. Today, really, it is going to be a very interesting case of tuberculosis triggering HLH, which is really very interesting. I am also interested to listen to this. So I am sure that the presenter Manbir Singh and the expert Meenu Singh, I know her very well, Vyas Kumar sir, and definitely it will be a very good platform for learning. Surely for next program, madam, definitely I will spread the message in a better way so that many people and we will try to incorporate with our Digi Academy also so that through IAP also the and academics can be spreaded, madam, along with you. Definitely we will plan and discuss without wasting much time, madam. Thank you for giving me wonderful opportunity, and we will work together for the betterment of the children, whatever form it is. Of course, tuberculosis is one of the very important, still hidden infection, which is not properly identified, not properly investigated. Still, it is existing different kinds of TB. Now, to the present task. Thank you. Thank you. Over to you, madam. Thank you.
The encouragement, they mean a lot to the people who have logged in, and especially because there would be a few pediatricians also. But as you have pledged, you will be extending full support and spreading this message. So without wasting time, now I request the team to start their case, please.
Yes, sir. Thank you so much, ma'am. Today we'll be discussing a case of TB triggered HLH. Case expert for today will be Professor Meenu Singh ma'am and Dr. Vyas Kumar Rathod, sir. So this was a case of Miss X, who was a 2-year-old female child resident of Bareilly, Uttar Pradesh, informed her parents. Date of presentation to AIMS Rishikesh was 8th of February this year, and current status of patient is in PICU. So the patient presented with chief complaints of fever.
I think your voice is not clear. I think, is it not? Is it for me or all? His voice is okay? I am not able to hear properly.
Yes, sir. Yes, sir. Voice is not clear.
Yeah, there is some muffling. I mean, but this is the best I think. I think just take a little bit away if you can. I think that might be better. This is what. Let's try keeping the mic a bit away.
Yes, sir. Now is it better, ma'am?
Yeah, now it's better, but your volume is a bit low.
Okay, a bit louder, ma'am. So the child presented was a case of 2-year-old female child resident of Uttar Pradesh, and the child with chief complaint of fever for
volume is not there, audible.
So I think because now your volume is going down, they can't hear you. So please come a bit more closer.
Yes, sir.
You can keep it
Child
close.
Now it's okay. Yeah, let's see.
Child presented with complaint of fever on and off for past 3 months, complaint of fast breathing for 15 days, and complaint of abdominal distension for 15 days. Coming to the history of a presenting illness, the fever, which was documented to be around spikes of 105 degree Fahrenheit. Fever was intermittent with evening rise of temperature and associated with chills and rigor, relieved on taking medication. The fever which is there for past 3 months, the child took treatment on and off, which will come to in the case of treatment history. Apart from this, the child has completed fast breathing for past 15 days associated with chest indrawing, which lasted for last 2 days, and noisy breathing for last 2 days. Complaint of abdominal distension. Abdominal distension was present for the past 15 days, which was insidious in onset and was gradually progressive. Apart from this, the child had one episode of seizure in the form of abnormal movement in the form of generalized polychloric seizure just before presentation to the case. These are the chief complaints. Now coming to the negative history, there was no history of joint pains, skin rash, loose stool, vomiting, bruise deceleration, travel to forest region. Coming to the treatment history for the complaint of fever, which is present for the past 3 months, in the month of December, child took some oral medication on OPD basis, and fever was responding, but it was not. It was on and off intermittent fever with intermittent spikes were still present. When the child had started complaining of respiratory complaints, like in the form of fast breathing and abdominal distension, child was taken to a private practitioner where child underwent some investigation and oxygen supplementation was given along with IV antibiotics and 2 unit PRBC and 1 unit platelet was also given. However, at presentation to AIMS Rishikesh, the documents we were not able to trace. There was no documentation. The child only had some formal reports with her and no discharge card or a treatment summary was provided to the child. And in the month of February, child presented to AIMS Rishikesh for further management and workup. Coming to the other relevant history of TB contact. Child had a history of TB contact present in the paternal cousin who was a 14-year-old female child who was diagnosed with query pulmonary TB and died 4 months back. So when we came to the contact tracing, as this was our index case, this is supposed to be an index case of 14-year-old female child. The child took ATT for 4 months as per the history given by the parents. This child took his ATT for 4 months, which was taken over the registration in the Nixia format could be traced, and it was not done. And the child took ATT on and off. Compliance was also poor. This cousin expired 4 months back. Query pulmonary TB, and this was not a sudden death. The child was having respiratory complaint, fever on and off, went on and off to some private practitioner, but didn't took the follow-up completely and eventually expired. And the child was not even taken to the hospital before any terminal event. So they could not ascertain that history, and unfortunately, that child was lost. Past history, there was no history of similar complaint or hospitalization in the past for this child. Birth and development history, child was not having normal birth and developmental history. Coming to the dietary history, child consumes only meat-based diets with calorie and protein deficit of 210 kilocalorie and 8 gram per day. The child is immunized as per NIS, as per the history. However, no formal records of immunization could be traced, and BCG scar was absent in this case. Socioeconomic history, child belongs to the lower middle class as per modified focus study scale. Shall I proceed now, or there will be some discussion on the history?
Yes, I think we can proceed. We can discuss after we have completed.
Okay, thank you. On presentation to AIMS Rishikesh, the vitals of the child are as follows. Heart rate was 132 beats per minute, respiratory rate of 46 per minute, saturation on room air was 94, blood pressure was 82 by 55 millimeter of mercury, temperature was 102 degree Fahrenheit. On general physical examination, only pallor was absent, rest icterus, cyanosis, clubbing, lymphadenopathy, and edema were absent. Coming to the anthropometry, weight of the child was 10 kg, which is at minus 2.1 standard deviation. Height of the child is 83 centimeter, which is 1.2 standard, minus 1.2 standard deviation. BMI of the child is 14.5 kg per meter square at minus 1.5 standard deviation. Weight for height for the child was minus 0.4 standard deviation. Head circumference of the child was 43 centimeter, which came between minus 1 to minus 2 standard deviation, and mid upper arm circumference of the child was 11.2 centimeter. Which is classified as severe acute malnutrition. So coming to the triage assessment of the child, the pediatric assessment and pentagon, which consists of airway, breathing, circulation, distribution. In this, the physiological characterization of the child was having respiratory distress. Coming to the respiratory examination, on inspection, the child was tachypneic, trachea was centrally placed, chest wall was normally shaped, subcostal and intercostal retraction were visible, but and with minimal nasal flaring. However, there was no dilated vein or scar marks. On palpation, bilateral chest expansion was present and symmetrical, and differential chest expansion was also equal bilaterally. On percussion, resonant node was heard on bilateral chest wall in all the areas, and on auscultation also bilateral equal air entry was present in and bilateral vesicular bed sound were present with bilateral diffuse crepitation heard in all regions. Coming to the abdominal examination, on inspection, abdominal was slightly distended with umbilicus shifted downwards with no visible dilated vein or scar mark. On palpation, the abdomen was soft, non-tender. Liver was palpable around 4 centimeter below costal margin, soft in consistency and with palpable left lobe. And liver span of the child was 13 centimeters, signifying hepatomegaly. And spleen was also palpable 2 centimeter below costal margin, which was soft in consistency, again pointing towards splenomegaly. Percussion, liver dullness was noted till 4 centimeter below costal margin at mid-clavicular line, and Trobbe's space on percussion revealed a dull knob. Auscultation, bowel sounds were heard normally, and no abdominal bruit was heard. Coming to the cardiovascular examination, on inspection, precordium appeared normal. Apical impulse was seen in fourth interspace and mid-clavicular line with no scar mark or visible diaphragm vein. On palpation, peripheral pulses were well palpable, regular, and apex beat was felt in fourth intercostal space and mid-clavicular line. Percussion cardiac dullness heard in left hemithorax with no evidence of pericardial effusion or cardiomegaly, and on auscultation, S1 S2 were heard normally with no gallop rhythm or no murmur. Coming to the CNS examination, although formal CNS examination could not be done at the time of taking triage, emergency triage, higher mental function, the child was irritable, having GCS of around 13/15. Child was irritable. However, there was no sign of cranial nerve lesion. Spine was normal, and grossly motor and sensory examination were within normal limits. So, based on the history and examination, we kept the diagnosis of first diagnostic possibility which we kept was a case of disseminated TB, query pulmonary, query CNS, query abdominal. Points in favor were a history of TB contact, and points against was there was no history of weight loss, and there was also no history of cough. Second, we kept the possibility of tropical infection, most likely scrub. The history was compatible, however, there was no sharp marks. The third, we also kept the remote possibility of malignancy. History was compatible. However, the point against was that there was no lymphadenopathy. And fourthly, we kept the possibility of some autoimmune disorder like macrophage activation syndrome or query SLE played. Points in favor were multi-system involvement, and points against was there was no family history. Also, the age of presentation of the child is around infantile, only around 2-year-old child, and there were no skin or joint involvement. These were the differential diagnoses. Should we discuss that?
Go ahead.
Yes. Coming to the investigation, on the 9th of April, these were the investigation. The child had a hemoglobin of 8.2, total leukocyte count of 3,260, differential leukocyte count revealing neutrophil 53% and lymphocyte of 42%. Platelet count had thrombocytopenia with platelet count of 39,000. ALT of 38 international unit, AST 190. There was cholecystitis as ALP is 693. Total protein and albumin were 4.993 respectively. Now, blood urine nitrogen and creatinine were blood urine nitrogen and creatinine was 2.63. The pH level of the child was elevated. It was 970.
Please. You're going a bit too fast, and your voice is not all that clear. So please go comparatively slow, so that people can hear you. And there is a gap between what you are speaking. Like hemoglobin 8.2, TLC 3.260, something like this, so that it's clearly audible.
Yes, sir.
Repeat kindly, because people can't hear you. They're repeatedly we're getting the feedback. So that was the reason I had to interrupt you.
Hemoglobin level was 8.2 gram per deciliter. Total lymphocyte count was around 3,260. Differential leukocyte count revealed the neutrophil of 53% and lymphocyte of 42%. Platelet count, child had thrombocytopenia with platelet count of 39,000.
Dr. Manmeet, I'm sorry, I'm interrupting you again. I think it's better if you remove the mic. I think this problem is coming because of the mic. You can just disconnect it and normal, you can speak with it. Your laptop must also be having a microphone. I think it would be fine after that. Okay. Then
सर अपने लैपटॉप का माइक्रोफोन का वॉल्यूम चेक करिए आई थिंक वहां से वॉल्यूम कम है
Now is it better, ma'am?
yes,
It's definitely better. So I think
you can continue now.
Yes, ma'am. So ALP of the child was 38 and AST of 190 with ALP level of 693 indicating cholestasis. Total protein and albumin of the child was 4.9 and 3 grams. Nitrogen of 37 and creatinine of 0.33. LDH level of the child was raised, which was around 978. Fibrinogen child had hypofibrogenemia, which was around 108. Triglyceride level were raised, it was 4,438, and ferritin was markedly raised, it was 8,856. And CRP was also raised, it was 132. This on the right side of the screen is the chest X-ray APB of the child at the time of presentation. Here you can see that the trachea is centrally placed with trachea centrally placed with bilateral. There are diffuse coalescence areas of consolidation. The costophrenic angle is acute. There is no cardiac silhouetting. Cardiac borders are well marked out, and cardiophrenic angle is also good visible. And there is no sign of effusion and no you can say that no radiological evidence of highly suspicious of tuberculosis in the form of fibrocavitary lesion or biliary pattern. We also get an ultrasound done on the same day, which revealed that the liver was enlarged. It was 13 centimeter with altered ecotexture. Spleen was enlarged 14 centimeter. However, there was no evidence of enlarged lymph node or granuloma. Mild free fluid was also present in the abdomen. Coming to the database, the child had severe pneumonia with respiratory distress, with pancytopenia, with seizure, with hepatosplenomegaly, with history of TB contact. Query suspected disseminated TB. Should I continue, ma'am?
Yes, please.
Yes, ma'am. Diagnostic possibilities after our baseline investigation history and we can was secondary HLH. Etiology very infective, and in fact, infection we kept the possibility of disseminated tuberculosis as the first one. Points in favor of secondary HLH was HLH criteria of 1994. 6 points out of the 8 were fully fulfilled. Points against was we didn't have any organism isolate indicating infection, and also bone marrow investigation were pending. Second possibility which we kept was familial HLH. Points in favor was it was an early age of presentation, and points against was there was evidence of TB present in the form of history of TB contact, and also in familial HLH there was no points against was there was no significant family history which could point towards familial HLH. So coming to the management, in respiratory management, initially the child was kept on heated humidified high flow nasal cannula at the time of presentation, which was on.
I will stop here because let's have some, if we can see if audience have some questions with regard to the case. So are there any questions from the audience up till now? Any questions from the audience? Or shall we proceed? We can proceed then, and then we'll take questions. Okay, Dr. Manmeet, you can proceed.
Management of the child in our hospital. Initially, the child was kept on heated humidified high flow cannula, which was only for past 2 days. Gradually, we have to upgrade the child on invasive mechanical ventilation. If this was the chest X-ray which was taken post intubation of the child, which was on 10th, that is after 2 days of presentation to in Rishikesh. Here you can see that the there is umbilical tube in situ, and also the chest X-ray has worsened in the form of there is loss of aeration. Earlier, we could make out that around 6 to 7 spaces were visible bilaterally. Now only 5 to 5 are visible, and also bilateral diffuse energy infiltrates are present with umbilical tube in situ. So we suspect at this point of time the child had type 1 respiratory failure. So we had to intubate the child and kept the child on invasive mechanical ventilation. And we shifted the child to PICU on 10th of February, keeping this in mind. And gradually the child was kept on invasive mechanical ventilation for a good 15 days. And on 26th of February, we could extubate the child and there was a HLH. So this is the chest X-ray of the child at the first day of extubation. As you can see that in between these two chest X-rays, there is significant radiological improvement in the right middle and lower lobe, and also there are no evidence of pleural effusion. There is no evidence of miliary pattern. There is no evidence of pneumo or any other ventilator associated complication. However, there you can see that there is slight enlargement of the trachea. Some tracheomegaly is there, which was gradually given only HFNC support, and currently the child is doing well on it is unified high flow nasal cannula. Coming to the cardiovascular, the child was hemodynamically stable for around 4 days, and the child was after that post intubation on the fourth day, the child was started fluid policies and iron drops were started area and working the form of area and omega. Maximum well-selected infusion score for the child which was 40, and these iron drops were tapered off within 2 days at 14th of February. Since then, the child has been hemodynamically stable, never requiring any fluid policies, and with good signs of perfusion. Coming to the sepsis and pneumocoagulation, at the time of presentation, since the child had prolonged illness
I'm sorry, Dr. Manmeet, your voice has started to break again. Have you disconnected the mic?
Yes, ma'am. Yes, ma'am. I'll try to be a bit more slow, ma'am. Yes, ma'am. So coming to the sepsis and immunomodulation, or at the time of presentation, we started the child on injection meropenem and teicoplanin and started our investigation. We also sent cultures, and on 11th of February, that is third day of our hospital stay, we could isolate ET net positive, which was found out to be rifampicin sensitive. So we started the child on ATT with steroid, keeping the possibility of disseminated TB, query TBM, and also with the evidence of alveolo-capillary block, since the child had a bad chest X-ray, and also the ventilator settings were very high in the form of ARDS. So we started the child on full dose DEXA at the rate of 0.6 mg per kg per day in 4 divided doses, along with full dose ATT. However, we had to shift the child past after 2 days. We also did a routine LFT and had received drug-induced liver injury in the form of transaminitis with ALT of 51 and AST of 280 with total bilirubin of 3.4845 and that bilirubin component of 2.27. So we changed the ATT to modified ATT and started the child on amikacin, levofloxacin, and ethambutol. And after that, since on after shifting to PSU on 10th, we did the bone marrow aspiration and biopsy of the child suspecting HLH, since our earlier workup in ER revealed that child was having features of hyperferritinemic sepsis query HLH. So we did bone marrow aspiration, which revealed hemophagocytes. And based on that, we started the child on immunomodulation. And on 14th, we could procure IVG, which we gave at 2 grams per kg over 2 days, and started the child also on injection methyl prednisone plus at the rate of 10 mg per kg per day as a part of immunomodulation for HLH. Coming to the ATT, after 7 days of starting modified ATT, we gradually introduced rifampicin first, and after that, after 3 days again, we introduced isoniazid, and subsequently after 3 more days, we were able to add pyrazinamide and change the regimen to from modified ATT to regular dose ATT. During the course of PICU stay, the child had growth of commensals as per the local biogram. So we started the child on injection colistin and injection caspofungin in view of prolonged hospital stay and thrombocytopenia, suspecting Acinetobacter baumannii infection. Coming to the hematological aspect, as I mentioned earlier, we did bone marrow aspiration and biopsy, which was reported on 14th, which we got as hemophagocytes and macrophages with mitochondrial ratio of 3.5:1, with no atypical cells, confirming our diagnosis of HLH, and hence we started with the immunomodulation. During the entire course of PXU stay till now, the child has received 6 unit RDP and 1 unit PRBC as per unit policy. Coming to the neurological assessment, the child was started on injection leveracetam at rate of 40 mg per kg for seizure. No episode of seizure during PSU stay, and after that, the child had. We did bedside fundus examination, which showed presence of choroid lesion, which were highly suggestive of choroid tubercles, with no evidence of papilledema. On during the time of PSU shifting on 10th of February, we did an NCCT head, which revealed uh, round subcortical calcification in right frontoparietal region, calcified granuloma. These are the CT images. In the first image, we can see that there is evidence of some mild hydrocephalus and mild cerebral edema is there. And in this cut, we can see that there are two bright hypointense lesions, which were reported as query calcified granuloma. Was about that we were able to do contrast enhanced MRI brain with screening, which revealed enhanced exudate and calcification along with tuberculoma. This is first one is the T280 image. As you can see in the right occipital and parietal region, there are some evidence of tuberculoma. In this image, this is T1 weighted image. Here also we can see that there are similar findings. There are query tuberculomas in the right frontoparietal region, and this photos show the third photograph shows that there are exudates which are very diagnostic and characteristics of tubercular meningitis. So the final diagnosis as per our unit was disseminated TB with TBM with tuberculoma with pulmonary with the secondary HLH with drug-induced liver injury which was resolved with MODS with ventilator-associated pneumonia with seizure. Current status of the child. Currently, the child is in PICU step-down unit on oxygen via nasal prong. Hemodynamically, child is stable. Child is on ATP with steroid, with injection caspofungin, colistin, meropenem, and vancomycin. Any questions, sir?
Yeah, any questions from the audience now? So we have the case has been presented, and any questions from the audience now? So Dr. Bharti Khernar are asking about the CSF findings. Dr. Manmeet, if you could share the CSF findings.
The notification.
Initially, the child was hemodynamically unstable, as we mentioned that till 14, the child was on inotropic support, and later on, we were quite certain that he had isolated rifampicin sensitive TB, and also we planned in between, but we are not very concerned about the CSF, so we could not do CSF because the child was initially unstable and later on they give negative consent.
Okay.
There is one more question regarding the antibiotic. Why the meropenem and teicoplanin was given? Is this given empirically or any?
Yes, sir. Sir, the child was given these antibiotics as the child had child was having child was having neutropenia and with evidence of hyperferritinemic sepsis. So we had guards high that we upgraded antibiotic first hand to higher end antibiotics, sir. Because the child was having neutropenia, as we can say, the TLC count was only 3000 with pancytopenia. So that's why we gave higher end antibiotics in the first go. Also, the first chest X-ray, as you can see, there are infiltrates. So we were suspecting that child child will be having a severe pneumonia, and that the child did after 2 days of HFNC trial, the child was intubated. So that's why on the first day itself we started the child on meropenem and teicoplanin.
Even then, if you have used these antibiotics, this is totally rational combination. You are using colistin, vancomycin, meropenem. So if you are going to use uh, what you call higher antibiotic, there is not higher antibiotic, but there is a plan to use. So you can't use a 4 or 5 antibiotic in a particular patient unless we have a definite one. So you are working in AIMS. So you should have asked for carbo expert in this patient. You should done the other investigation which are available to look into that what is happening for the VAP. You have got all facilities. So CARBA should have been done in this patient so that we can use only limited amount of antibiotic. So because this misuse of antibiotic is going to give rise to antibiotic microbial resistance, and that's a big concern all over world, especially in India.
Yes, sir. Sir, sir,
So,
initially,
expert to comment because I mean Dr. Ashwini Sudhir raised serious concerns.
on ET respiratory PCR and ET culture later on we isolated accelerator factor how many? So that only then cholesterol was added. And it was as per culture sensitivity report. It was reported as intermediate sensitive to cholesterol. Cholesterol we also added.
Is Dr. Meenu Singh there?
Yes.
Dr. Meenu Singh, if you are there, I would request you to please step in because and clear the doubts.
I don't think Sangeeta, she is there. I don't think.
Yeah, I think she might be busy in a meeting with the
Yes,
director.
yes,
Is there
yes, yes.
else from AIMS Rishikesh Pediatric Department? Oh, sorry. Yeah, Pediatric Department.
Hello, good afternoon, everyone. Am I audible?
Yes, yes, you are. Vyas, Dr. Vyas, can you kindly comment upon the antibiotic choice?
Yes, ma'am. Actually, this patient was referred to us in a very sick state. जो है, initially itself, the patient had means ventilatory requirements, and the patient presented with MODS. So this was actually जो है, these all antibiotics were not started upfront in one go. It was later on increased, and at some point जो है, it was decreased also. So we started with meropenem, but the child didn't respond. And initially, for first 3-4 days, we didn't have the diagnosis. The ET culture, CBNAT, that came positive after 3-4 days. So then only we added ATT along with it. So yes, definitely we should have sent for culture reports, and then later on it could have been modified. But this colistin was also not added up front. The child later developed ventilator associated pneumonia. So for that, later on colistin was added. So these all antibiotics were not going at the same point, same time. So I hope I'm clear.
Dr. Ashwini, are you satisfied?
So if I do that in their place, right, when we get a sick patient, we do use meropenem and vancomycin. But as we right now, rightly they have said that they have done it. Once they got the confirmation for mycobacterium disease, then I said the antibiotic use should have been more rational, because this program is being going to whole of the country. So at least let's try to give that how optimally we are going to use. I'm not against using Miro or anything, but the combination has to be rational one, and it's a center like AIMS, so they must be having carbo expert with them. So that would have been the better investigation, so that we can minimize the misuse of antibacterials. They have done everything right. Yes, they are right in their place, because we were not following this patient, but that is my observation. So that we need to be careful, and especially when once we have diagnosis of tuberculosis, then the antibiotic use should have been more and more rational.
very well taken. I think important thing is that rational use of antibiotics and ATT was started as they got the CBNAT report RIF sensitive. So, any other question?
Is that is there any fungal or any other bacterial infection was found in the blood sample or in the tube?
Yes, sir. Sir, in ET, respiratory PCR which we sent and ET culture which we sent came out to be positive for Acinetobacter baumannii, revealing intermediate sensitivity cholesterol. So that's why cholesterol was added. And for as far as fungal workup, sir, we could not get direct evidence of fungal growth, but there was persistent thrombocytopenia and also patient has prolonged ICU stay after 20 days only. That's when we did injection cascophage. Pure persistent thrombocytopenia and hyperglycemia.
So, Dr. Sangeeta, just one brief comment. For cholesterol, as on today, world over, we get intermediate sensitivity. So that doesn't mean that drug is not effective or non-effective. That's a standard protocol as per the CLI. So one need to remember that.
Yes. Any other comment?
So in this case, basically, how you decide to give the immunoglobulin versus dexamethasone or any other apopsites?
Yes, sir. Sir, in HLH immunomodulation, various modalities of HLH immunomodulation are there in the form of injection with methylprednisolone pulse, dexamethasone maintenance, IVIG, and also there is a role of biologicals and as radiocontrol at etoposide as well. So, sir, as far as the review literature goes regarding the TP-triggered HLH, which is our case, there have been mortality benefits, and the highest mortality benefit has been reported with IVIG. And also, initially, which we had our suspicion that HLH could also be mimicking like hypercreatinic sepsis and MAS. So that's why we gave injection IVIG along with methylprednisolone first. During the methylprednisolone first, we withheld dexamethasone, sir. For immunomodulation combined therapy, has yield better prognosis as compared to single modality of therapy. And the best results were obtained with the IVIG as per recent systematic review and meta-analysis.
So one more question after the starting the ATT, the liver enzyme as you told in your presentation. So these liver enzyme is raised due to the ATT or any other cause, just like due to HLH?
Sir, we can not be sure, sir. As we can see that at presentation, at presentation total ALT was 38 and AST was 190. And after starting ATT, sir, the liver enzymes were raised. AST was 280 and total bilirubin was also raised, which is more than 2. So we suspected disease, sir. So to be on safer side, we converted cell to modified ATT. Per se, in HLH also hepatitis and transaminitis could also be there. Rarely pointed out, but just to be the benefit of, we proceeded with this approach of attributing it to ATT. And we shifted to modified ATT.
So how long you give these modified ATT? How long duration?
Yes, sir. Modified ATT was modified on 13th, and after that, around within 2 weeks, we were able to reintroduce full dose ATT. Just for 2 days, 2 weeks, sir.
There's another catch here. In both liver enzymes, only one is raised. Other one was in the normal range. You can see ALT is 51, AST is 280. So even it doesn't qualify as per the definition. 5 times of the normal. I don't have an idea what was the normal. And secondly, best thing to pick up HLH is drop in ESR. Because this is because of hypothermia. So that should be remembered.
And even a single value coming to 80, it warrants that you have to put the child on the modified regimen. Because the child is sick, that was the reason the modified regimen was given. this child would not have in any case tolerated rifampicin, INH or pyrazinamide. So they are correct on the ATT part. The only concern which I feel is that blood cultures, sputum pyogenic culture, they should have been sent, and the antibiotics they could have been fine tuned accordingly. But as per ATT, I'm quite satisfied. It's approach which we recommend. So, any other question?
Ma'am, Dr. Kamal this side.
Yeah, Kamal.
So, ma'am, I fully agree with you, ma'am, that it is not that you both ALT and S2V are to be deranged. If a derangement is there in any one of them, technically it becomes drug-induced liver injury. Now, the point is whether the injury is because of drug, it is because of the disease per se, or a third thing which is affecting the liver. But in a child like this, when the child is critically sick, whatever be the reason, ultimately the drug will be metabolized by the liver. If there is an injury in liver, we will have to modify these drugs. So it doesn't have to be that there is no way you can prove that it is only the drug which has led to this. It may be the liver was damaged because of disease per se. In that condition also, ultimately you will have to modify the anti-tubercular therapy, because it can cause damage and it has to be metabolized through that place only. In our guidelines also, 40 is what we take as upper limit of normal, and in that sense thrice is 120 and 5 times is almost 200. So but yes, the message should be that once you have modified anti-tubercular therapy, you're giving that modified ATT, you should try to reduce that period when the child is on modified ATT, because it's a compromised regime that is not taking care of a severe form of a disease or a complicated disease. So as soon as possible, one should try and come back to that. So every 3 to 4 days also you can look for those values. If they are within normal limit, add a drug. Thank you.
They did that. I mean, they've achieved the full ATT very fast. So I think on that account there is no issue at all, because irrespective of whether it was the egg came first or the hen, the end result is that the liver is showing derangement, and we need to modify our ATT. There was some derangement right before the ATT was started also. So it could have been because of the disease per se, because we are looking at a case whose case of HLH. And then on top of that, the ATT has to be started because it came as MTB detected, RIF sensitive, and we have 3 hepatotoxic drugs. So that led to further deterioration of LFT, and they did a good job. They modified the regimen, and they were able to stabilize the child. Any other question? I can see one more question.
Most of the question are taken.
Is there Mazhar? Dr. Mazhar, you want to ask, or is it who wants to ask the question? Picture. What is the indication for
Casper fungus.
Yes, there is a question. One more question.
Yeah, Dr. Manmeet, one of the audience wants to know what are the indications of using Casper fungin.
If we use fungin in view of prolonged hospital stay and persistent thrombocytopenia, which we attributed to suspected thrombocytosis,
Vyas to say, because your voice is totally muffled. Dr. Vyas, can you please take over this answer? Sorry, I mean, because his voice is totally muffled. Dr. Vyas, yes, please. Your voice is much better.
Ma'am, actually, the child already had persistent thrombocytopenia, and later on, this thrombocytopenia was worsening also. And in between the hair condition for 1 or 2 days, it worsened. So in view of that, the child was on prolonged higher antibiotics. They had already on ventilator. This child was already on ventilator, and even there was the child was behaving like immunodeficient child due to all multi-organ system involvement. So because of that, in view of persistent thrombocytopenia and worsening, this caspofungin was added. And we sent for urinary KOH and other fungal workup, but that came negative, and later on that was stopped.
So can you, because then they are not pediatricians. There are people who are district TB officers, state TB officers. So can you just give what is caspofungin and what are the indications for the benefit of the house, just in brief?
Yes, ma'am. It's a broad spectrum antifungal drug, caspofungin. So whenever we are suspecting fungal infection in an more like means in severe sepsis, they have, when you are suspecting when the child is slightly malnourished, and if the child is on broad spectrum antibiotics for a longer period, and then you suddenly get some deterioration. So in all those cases, we think of fungal sepsis, and we try to add antifungal in those cases, because that is one infection, fungal infection, that can very rapidly deteriorate your child. So all the benefits which we have gained through adding IVIG and managing HLH and tuberculosis will suddenly wane off. So that's why, in view of that, only caspofungin was added.
There's another question about the indication of IVIG in HLH. So when is IVIG indicated?
Ma'am, as far as HLH treatment goes, in as per 2004 guidelines, ma'am, immunomodulation is advised, which would be in the form of IVIG, injected methylprednisolone pulse, dexamethasone maintenance, biologicals, and etoposide. As per the systematic review and meta-analysis, combined therapy has proven to be better than monotherapy, and in amongst the various modalities of treatment, IVIG has proven to be of best survival benefit. And moreover, in case of severe sepsis, when we are of the opinion that giving methylprednisolone pulse could, that's what, since our child was on invasive mechanical ventilation, had shock, hemodynamically unstable with mods. So IVIG, that's why we gave our child IVIG, and also low dose methylprednisolone pulse, of 10 mg per kg per dose for 3 days only. So that was the indication of IVIG.
Okay.
Dr. Sangeeta.
Sir, one second, sir. I will request the audience to please attempt the post-test questionnaire as well. In the meantime, we're having a discussion.
Mike, Sangeeta, may I request Dr. Vyas to reproduce what Dr. Saab has told? I could not understand what Mr. Singh has told.
Yes, the voice is muffled. Dr. Vyas.
Yes. So we can request Dr. Vyas to reproduce the same sentences.
Yes, sir.
Thank you, Dr. Vyas. Thank you.
Thank you. Yes, sir. In cases wherever we are suspecting HLH, be it due to tuberculosis or due to any other infections, it is now dictum to add immunomodulation, and in that IVIG comes first. Usually,
Yes.
It has seen कि if you are adding IVIG along with steroids, so that works better. If you have got any case of tuberculosis with HLH, so if you are treating only with anti-tubercular drug, so in that case, the survival benefit is roughly around some 50-55%. If you are treating TB with HLH with anti-tubercular drug along with immunomodulation like IVIG and steroids, the survival benefit is somewhere around 66-70%. So that gives a edge over just adding ATT only. So in any case, you have to treat HLH with immunoglobulins and steroid. So if you are not giving any of those, so survival benefit is around 0 only. Means you won't be able to save the child. So in any case, if you are getting TB with HLH, it's always better to add ATT along with immunomodulation in the form of IVIG and steroids. So am I
Thank
clear?
you. Thank you, Dr. Vyas. Thank you.
Sir, Dr. Vyas, how long you recommended to give the steroid actually after tapering the IVIG? Any, sir?
Hello.
Hello. My question is that after giving the IVIG, you shifted this child to the steroid. So how long, as per your, in this case, how long you give the steroid in this case?
Usually जो है for 2 to 3 weeks usually जो है we prefer to till that we need immunomodulation जो है till that period जो है till HLH part जो है is taken care of, so that usually takes care in 2 to 3 weeks. So in tapering dose जो है we can add for 2 to 3 weeks.
Okay, thank you. There are any questions?
If questions should be.
CSL.
Any more questions? Any more questions from the audience? If there are no more questions, we can wrap up today's session.
No, they have to do that.
Achha, sir. Okay, Dr. Manmeet, you can proceed with the didactic now.
Yes, ma'am. So, ma'am, I'll be jumping to the HLH part. Hemophagocytic lymphohistiocytosis is a rare life-threatening hyperinflammatory syndrome with uncontrolled activation of macrophages and cytotoxic T cell into cytokine storm and multi-organ dysfunction. It accounts for about 1 in 200 cases which are referred to in healthy care sector. So coming to the HLH classification, it is classified as primary HLH or familial HLH, which is caused due to basically genetic mutation which affect the functioning of cytotoxic T cell or NK cell functions, usually present in infancy or childhood. And the second case is of secondary HLH or acquired HLH, which occurs secondary to infections, malignancy, or autoimmune disease, like occurred in our case due to tuberculosis. Firstly, infection-triggered secondary HLH accounts for about 25% of the cases, and amongst those infection-triggered TB accounts for 10 to 25% of the cases. So TB, although as world over is rare, but in considering our setup, which comes under high burden category as per WHO classification, is an important cause which needs to be ruled out in whenever we are considering a possibility of secondary HLH. The common manifestation.
Dr. Your network got garbled again. Can you please repeat that incidence point once again, please? Sorry. Thank you so much.
Yes, sir. Sir, for as far as incidence is concerned, sir, amongst all the cases of secondary HLH, as far as 25% of secondary HLH are triggered due to any secondary underlying infections, among which viral infections are the most common, but TB also is a significant contributor, which accounts for as many as 10 to 25% of the cases of secondary infections which trigger secondary HLH. So, as per the systematic review and meta-analysis, the WHO has classified world regions into low TB endemic and high TB endemic areas. But the incidence of TB triggered HLH are comparable. It is around 35% in the case of low TB burden areas and in high TB burden areas like India. So whenever we are suspecting a case of HLH and primarily secondary HLH, then we should definitely work up the patient for tuberculosis in our country as TB is endemic in our region. I hope I'm clear.
Yeah, a little better. But again, you said in the high burden areas, 50% bataya aapne, 35% bataya?
40%, sir.
40. Thank you so much.
Coming to the manifestations of HLH, common clinical manifestation of the patients are persistently high-grade fever, hepatosplenomegaly, lymphadenopathy, respiratory symptoms, fatigue, and weight loss. And severe manifestations are ARDS, multi-organ failure, shock, and neurological involvement. In our case, almost every severe manifestation was there, and apart from lymphadenopathy, weight loss, and fatigue, our common clinical manifestations were also present. Coming to the laboratory finding in HLH, hematological finding could be pancytopenia, anemia, thrombocytopenia, leukopenia. Biochemical findings are per se elevated ferritin, hypertriglyceridemia, hypofibrinogenemia, elevated liver enzymes, and bone marrow findings are classical, which are hemophagocytosis, macrophages engulfing RBCs, WBCs, and platelets. So this is the HLH 2004 criteria, which for the diagnosis of HLH requires only 5 out of these 8 criteria, namely fever, splenomegaly, cytopenias affecting 2 or more cell lines, hypertriglyceridemia or hypofibrinogenemia, hemophagocytosis in bone marrow or lymph node, low NK cell activity, ferritin level more than 500 nanogram per ml, and elevated soluble CD25 level. In our case, 6 out of these 8 criteria were fulfilled, and per se also in low resource setting, about 5 of these could be done, and we can very well pick up HLH. So coming to the TB HLH, which I mentioned previously, infection is 25% of total HLH cases. Of these 25% of TB overall, and low and high burden countries are estimated 35 and 40%. Coming to the pathophysiology of TB HLH, immune dysregulation and cytokine storm are the central pivotal points for TB HLH. So coming to the left side of the slide, in TB infection, affects the macrophages, which act as antigen presenting cell, and with the help of major histocompatibility complex 1, MHC class 1, are presented to CD8 cell. These CD8 cell in turn causes release of interferon gamma, which in turn activates macrophages and leads to inflammatory cascade. However, in HLH and secondary HLH, NK cell activity and natural killer cell activity is lost, so that's why this cascade goes on unregulated, and symptoms of HLH primarily due to cytokine storm and immune dysregulation. Furthermore, in cases of disseminated TB, what happens is the TB which was engulfed by macrophages is presented by PAMPs, pathogen-associated molecular proteins, which are recognized by toll-like receptors present on macrophages, which in turn activates the NF-kappa cells are primarily involved in case of disseminated TB. Furthermore, the bottom line is there is immune dysregulation and cytokine storm, which causes this manifestation of HLH. So, in case of TB triggered HLH can present as two cases. It can present as a case of HLH of unknown etiology and later found out to be TB, which was the inciting agent, which is a more common presentation as happened in our case. Or furthermore, it can also be that the patient was already a known case of HLH triggered paradoxically as on receiving HLH. Paradoxically on receiving, ATT. Am I audible? Lung is the most common organ involved, and increased mortality in case of TB triggered HLH is seen in case of bone marrow involvement. The treatment, there is 100% mortality if untreated, as in case of any secondary HLH, the primary pathology needs to be treated, be it any source of infection, be it any
Not audible now, Dr. Manmeet.
leukocyte, cyclosporin A, plasma exchange, and splenectomy. Per se, plasma exchange, cyclosporin A, and splenectomy are very less limited to role is limited to only some isolated case reports. Most widely used and dominantly used are corticosteroids and IVIG. So these were the options which we went for in our patient. So.
Dr. Manmeet, you had also mentioned in your previous slide about the
that TB may present as HLH and incidentally detected, so always detailed workup of for secondary HLH needs to be done. In case of TB HLH, treatment is to be combined ATT and immunomodulation. TB with alveolo-capillary block and TBM is an indication for corticosteroid therapy and contract tracing and TB preventive therapy.
Dr. Manmeet, you had also discussed about the indications of steroids in TB. I think you have. So can you just discuss for the benefit of the house, what are the indications of steroids in TB as per NTEP guidelines?
As per NT 2022 guidelines, these are the definite indication for tuberculosis as per pediatric guidelines, which include TB meningitis, pericarditis, Addison's disease, miliary TB with alveolo-capillary block, and TB uveitis. Furthermore, TB corticosteroids could also be used as per this, may be considered for the treatment of endobronchial tuberculosis, bronchial compression, mediastinal compression syndrome, pleurisy with severe distress, laryngeal TB, and TB immune reconstitution inflammatory syndrome. These are the major categories in which corticosteroids may be considered.
So, in your case, there are three concomitant indications which exist in your case. So that was the reason, steroid, because your case had biliary TB on the chest X-ray. Then there was TBM, there were basal meningeal enhancement, and HLH. So all three indications they qualify for steroids. And steroids, as you started methylprednisolone, and for these indications, for TBM, we give 4 to 6 weeks at the dose of 1 to 2 milligram towards the higher side, milligram per kilogram. So, and then to taper within 6 weeks.
Yes, ma'am. As far as HLH protocol goes, there we give a bit low dose dexamethasone at 10 mg per meter square per day. So coming to dose equivalent, it's roughly about the same which we gave for TB. So currently the patient is on maintenance steroid dexamethasone. Pulse was just
Patient now out of ICU responding well.
When the patient is in step down unit of PICU, hemodynamically the child is stable on full oral feeds. However, there is post-TB sequelae is there, neurological. Neurologically wise, the GCS is around about 12. Also, as I mentioned, that there was choroid tubercles. Once the patient was stabilized, we also get visual low potential done, which revealed delayed T100 latencies. So the ophthalmological evaluation of the patient is also still ongoing, and we are working on it.
And what about the hematological markers? The blood counts, they come normal? They settled?
Yes, ma'am. During the stay, ma'am, only the persistent issue was the thrombocytopenia was persistent issue, for which we gave 6-unit RDP. Last transfusion was about 10 to 12 days back, ma'am. Currently, the patient is having hemoglobin of 9.2. TLC count has stabilized to around 10,000. They have improved, and the platelet count is still in the
Viral infection, the child is accepting orally?
Ma'am, the child is on OG feeds, not orally feed.
They started to have some weight gain.
Miss, in the past 1 week, only 100-gram weight gain is there. But as far as admission and current weight gain is concerned, ma'am, it is static because the child when the child was came, the child was bit puffy and quite fluid overload. So now the child is beginning to on the status quo, ma'am. Initially, the child lost fluid in ARDS, which the child was having edema and pulmonary edema component was there. So now the weight gain has started. Nutritional rehabilitation is ongoing.
So any more questions from the house?
Full OGP since tapering and
Okay. Any more questions from the house? So if there are no more questions, I will request Dr. Alok to summarize the case.
So there is no more question in the chat box. So right now, I will summarize the case. This is a very good and interesting case, which is well managed by the AIIMS Rishikesh team. So this child is a 2-year-old female that was referred to AIIMS Rishikesh with the complaint of fever for last 3 months, fast breathing from 15 months, and abdominal distension from 15 months. As per the ST taken by the child, the contact ST was positive, and there is no BCG scar was present, but child was immunized as per the national immunization schedule. As per the mutational status, the child come under the same category. On the clinical examination, the child has tachypnea and hepatosplenomegaly. Fundus examination show choroid tubercles, and the child has one episode of the seizure. So CD had also show calcification in the right frontoparietal lobe with basal exudate. The blood investigation which shows raised LDS level, decreased fibrogen level, increased triglyceride level, and increased ferritin level. ET sample which was sent for CBNet was found positive and drip sensitive. Initially, the child was managed by the invasive ventilation. Later, the child was shifted on NIV and HFNCs. With inotropic support, pulse therapy was given as per the protocol of HLH with antibiotic, anti-TB treatment, and blood transfusion in PICU. Due to the raised liver enzyme, the child was shifted to the modified ATT regimen. Bone marrow biopsy also showed macrophages. So this is a very interesting case in which HLH is a very high fatal condition resulting from uncontrolled immune system trigger of the immune system by TB infection. Excessive cytokine release causes macrophages activation and phagocytosis of the blood cell in the bone marrow and reticulocyte counts. So the points which are in favor of HLH is the child is having fever, hepatosplenomegaly, and the lab reports also show pancytopenia, increased LDH, triglyceride level, ferritin, and decreased fibrogen level. Bone marrow also shows hemophagocytosis with macrophages. So TB infection contribute near about 10 to 25% of the HLH cases. Early diagnosis is very important, and the management required dual approach anti-TB therapy with immunomodulatory treatment such as corticosteroid and IVIG. So this is the summary of all the cases. Thank you.
We thank the AIMS Rishikesh team for this excellent case presentation. It was indeed a learning experience. There is one last question in the chat box which is asking about the genetic susceptibility tests like MSMD if they are required in such a case. So would you like to take up this question? The AIMS Rishikesh team?
Yes, ma'am. Genetic susceptibility could be a possibility, but as far as this case is concerned, the case was quite straightforward. So, but in the back of the mind, we can keep this possibility of maintaining susceptibility to mathematics.
I think C25 marker would be the best in such a case. And there is another question regarding the present coagulation profile.
Coagulation parameters, ma'am, INR was detained at the time of presentation. It was around 1.8, but there was no clinical manifestation of bleeding per se. So we didn't go ahead with any blood product transfusion or FFP. We managed conservatively with vitamin K only. So we didn't give any blood products. Cryoprecipitate or FFP were not transfused. And there were no thromboembolic, like DIC kind of events were not there. So we did.
Was decreased. The rest, all the coagulation profile markers were within normal limits. This is what you are saying?
No, coagulation profile per se was read. INR was around 1.8, 1.7.
Okay, sorry.
But there was no primary. So we didn't treat it per se. We managed it conservatively with vitamin K only. We didn't use any product for management. Were given FFP or cryoprecipitate were not.
So it's a very interesting case and a difficult case, and you managed it well. And we would hear the feedback in our next session also, because we are also very concerned about this case, how the 2-year-old child is progressing. Now, Dr. Dhulika.
Yeah, so on behalf of Team NITRD, I would like to thank Team AIMS Rishikesh for this wonderful case presentation. I would request the audience to please attempt the post-test questionnaire. And I would also like to request Dr. Ashok Bhardwaj National Task Force for his closing remarks.
So thank you, Dhulika. So it was, thank you, Dr. Sangeeta and your team, Dr. Yadav. So it was interesting. Yes, it was interesting, but very difficult case.
Yeah.
So but the AIMS Rishikesh team presented it very well. They are managing the case, and as Dr. Sangeeta told, we would like to hear in the next case what is the progress of treatment in this case. So it is all be there. But I have one comment for Dr. Ashwini Sood, if he is there. So he said that it's not expected from AIMS. So why you are downgrading yourself? Every pediatrician is maybe he is strong in itself also. He is clinically strong in itself also. So maybe the institution INIs may matter, but individual clinician or pediatrician, they are best in themselves. So thank you all the participants. Now I must thank Sangeeta, your president elect of IAP, who has promised and that the next time the attendance may increase. Not may, but will definitely increase through his words, because he has promised that he will circulate it to all the fraternity of pediatrician in the IAP. So thank you very much. Thank you giving me a chance. Thank you very much. Thank you.
So this is what we are here for. We require the support of each one of you. I mean, with folded hands, we are requesting, because the more we have logins, the more we learn from each other, and we always try to maintain an informal discussion, because this has to be extempore discussion, so that whatever doubt arises in the mind of any of the participant who is logged in should feel free to answer a question and get an answer and be satisfied. So with this, we thank you all once again. And now, Dr. Dhulika, do the announcements, please.
I thank all, and I hope you all have attempted the post-test questionnaire as well. So we will wrap up today's session, and we will meet again on 21st of April, and with a new case. The presenting team next month would be PGI Chandigarh. So let's meet again next month on 21st of April with a new case and a new discussion. Till then, goodbye. Keep reading and keep learning.
Thank you, everyone.